Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and most of us don't think about transplant medicine until it becomes personal. And when it does, that's when everything changes. Suddenly, you're learning new words, new risks, new timelines. It can feel like stepping into a completely different world. So today on Doc Talk, we're going to talk with someone who has been leading in that world for decades. Dr. Alan Langnas is a professor of surgery, director of the Nebraska Center for Transplantation, and chief of transplantation surgery. He also serves as the clinical director of the liver transplant and intestinal programs. He's been on faculty at the University of Nebraska Medical Center since 1989 and has led the transplant program since 1997. So this is someone who's seen the field evolve. He's seen families at their most vulnerable, and now there's a partnership that directly impacts patients right here in the Black Hills. That's what I want to dig into and what that really means. So welcome, Doctor, to the podcast. Thanks for doing this.
Thanks, Mark. Great to be here.
Well, now, when you hear that read back to you, do you hear 1989 and think, oh, boy, that's been a minute ago?
It's a funny thing about life is that, the old saying goes, the days get longer, but the years get shorter.
Yes.
And for sure that applies here. I mean, I vividly remember coming to Omaha from Detroit, which is where I came from. And now I look back on it and I cannot believe how many years it's been. And I had 3 children grow up in Omaha, and now they're on their way doing their own things. So, yeah, time goes quickly. The world moves on,
yes.
But it's all wonderful.
What led you into this, Doctor? When you were growing up, you were in high school. Did this where your journey has led you now? Did you ever dream that this is where it was going to be? Is this what you wanted to do?
So I appreciate that. I'm not sure I appreciate that question, but I get asked that question a lot.
Okay.
And I'm not that person, right?
Yeah.
I was an okay student in college, smart enough. I went to the University of Michigan as an undergraduate, go blue. Mm-hmm. But I went to school as sort of an environmental studies major. I was, outdoorsy. I was a backpacking and canoeing guide, that kind of deal. Tree hugger, however you want to characterize it, maybe old school hippie back in the day. And I don't know, I just sort of wandered my way, ended up in medicine. But I really got there maybe a little later, mm-hmm. And then became a surgeon because that really resonated with me, being a surgeon. I don't necessarily know that I wanted to be a doctor,
right?
But I thought I really wanted to be a surgeon. And, and then this just took me, this way and that way, and ended up in transplantation. So I wasn't one of these kids who knew it from the beginning. I was a late bloomer, so
Sure.
to speak, but I think that's okay.
Well, I think, you should tell your kids that, that's with my son. He's 19 years old, and I'm like, you'll find your way. I mean, you don't have to follow the path that everybody else follows. And, obviously it worked for you very successfully. Well, let's get into a little bit about why you're here, Doctor. You oversee a wide range of transplant services, liver and kidney and pancreas, small bowel, intestinal rehabilitation. For listeners who may not realize how complex this field is, can you kind of help us understand the full scope of what your team actually does on a daily basis?
Oh, my.
Can you even break that into a soundbite here?
So we become family.
Yes.
I mean, I think one of culturally what we do as a team and what we try to achieve is that we get sent patients from all over this region and actually all over the United States. And so first of all, I think that, as a program, we believe we have a responsibility to the region. I think we have a social contract, not just with Metro Omaha, Lincoln, but the entire state of Nebraska, mm-hmm. virtually all of South Dakota, western Iowa, Kansas, Missouri, at a minimum. And so I think as a consequence, I think we have a different we try to provide a certain type of experience for patients and their families, because the way it goes typically is somebody goes to see their doctor and they're given bad news. There's just no way around it. They get told, hey, you got dealt a bad hand. The stakes are high. Your health is in jeopardy. Your life is in jeopardy, or your family member's in jeopardy. Your child is in jeopardy. Your baby's in jeopardy. So it's a really impactful moment for all these families. So what we make sure of is that when they come to Omaha, so first of all, we provide a lot of care here first, but when they do come to Omaha, to the University of Nebraska Medical Center, to get sort of that front row seat to this experience, we talk to them about creating a partnership. We're going to be in this together. This is not go meet your doctor. This is the diagnosis. This is the plan. See you later. We're going to invest in your lives to help you on this really challenging journey. And so because of that, I think because of our approach, we talk about when people come to us at the University of Nebraska, we put sort of that warm blanket on you to help you kind of navigate really, really stressful, really difficult, really high stakes game for you or your family member.
So you've been part of this program since the late 80s. You've been leading it, like we said, since about the 90s. From your perspective, what's changed the most? That's one of the questions I love asking for people that have been in these fields for a long time. From what you've seen from back in 1989
right,
to how it's gone now, and I guess kind of a follow-up to that question would be, what are you most proud of in the changes in what you've seen in all these years?
Yeah, so in so many ways, nothing's changed.
Sure.
Right? So I think, the operations are kind of the same, Some of the medications are mostly the same. But I would say the things that have changed the most to some extent are the types of patients we're seeing. Some of the diseases that we see are different. So, for example, early in my career, hepatitis C did not exist. Somebody discovered it.
It didn't exist, really?
It didn't. Nobody knew what it was.
Sure,
it was called
okay.
non-A, non-B hepatitis. Nobody knew what it was due to. Oh. Then somebody in the late 80s, early 90s discovered this virus, and we said, oh my goodness, all these people have hepatitis C. And then we would transplant people, and we didn't really have good treatment for the virus, and people could get recurrent disease. And then new drugs came out, and now we've literally cured so many people either before transplant or after transplant. So sort of a disease was discovered, treatments were applied, and revolutionary curative treatment was then invented. So this is all in my lifetime, and I joke around a lot with people. I say, so in my medical career, HIV came out in like '82, and nobody knew what it was. Then it was discovered, and everybody was dying, and then suddenly we have treatment, and not a cure, but now there's good treatment, and people just live their lives. Just look at Magic Johnson,
right?
And then hepatitis C, another sort of epidemic. Didn't know what it was, discovered it, didn't know how to treat it, got treatment. Now it's just like not really a big issue. And then COVID for, that's sort of three, one person's lifetime is sort of three sort of things came in, right? So it's just like, so that just gets to your question about what's changed. Like the operations haven't really changed. If you come and watch me do a liver transplant, that operation is fundamentally the same as what I used to do, what I did in '88 to what I did last week.
Right.
It's the same operation. Some little tweaks here and there, but at its core, it's the same. I think sort of the exciting new things for us now is that we have new technologies. So the biggest barrier to people getting the treatment they need for whether you have kidney failure, need a kidney transplant, or you have bad liver disease, need a liver transplant, the biggest barrier to you getting that curative treatment is the donor organs, right? So we're still not like heart surgery or brain surgery. We just kind of get stuff off the shelf and we can fix you up and take care of you. You need to have a donor organ. And whether it's a deceased donor or a living donor, that still represents the rate limiting step for the whole thing. So we still always talk about organ donation.
Has that gotten better in your time in practice as far as people signing up more to be organ donors, or is it still a pretty big struggle to get the ones you need?
So I would say yes to both.
Okay.
Right. So I think we're still not. We don't have enough organs to meet the need because people still die on the waiting list. Right. So they're waiting for an organ transplant. They're waiting for that phone call. It's as dramatic as maybe we think about it or see about it on television or read about it or even imagine it. So that drama still exists. But saying that, when I speak about new technology, So two things have happened that I think have been the most dramatic. The first is something called first-person legislation. And I must confess, I'm not sure about South Dakota, but I know in Nebraska. So in Nebraska, when you go into the DMV to get your driver's license, they say, do you want to be an organ donor, right? And so you can check that box. And what they mean by first-person legislation is that if you check your driver's license, say, I want to be an organ donor, that's legally binding. So if something catastrophic happens to you, even if your family doesn't want to do it, it's going to happen, because your wishes have been put down on paper in a way that's sort of, regulatory-wise, legally binding.
Right.
And so that's really helped improved organ donation and our ability to get more organs for transplantation. And then the other thing that's gone on is that we've now got new technology. So we can take these organs, and it used to be just like you would imagine on TV. People, get a kidney or a liver, they take it out and they put it in the Igloo icebox, right? And everybody
immediately got to hit the plane.
Hit the plane and off they go, right? So that still happens, But now we also have these what we call machine perfusion. So we can hook it up to really a machine that will pump, human blood at the right temperature, at the right flow rates through these organs, and we can measure stuff. So then now, sort of these logistical issues get, eliminated. And, and sometimes these organs, we're not sure if they're going to be safe to use because we're not sure they're going to work well because the stakes are high. If I put a liver in you, Mark, and that liver was a dud, well, your life is in immediate jeopardy.
Right.
You're talking about days, right? And the stakes are incredibly high for you at that point. So our ability to put these organs on machines, sort of test them, give them a test drive. We can get lab tests. We can see how much bile it makes and do a biopsy. We can do all these sort of cool things. It allows us to say, you know what, Mark, not only do we think it's good, we've done even more. We know we've got a test drive. We're even more confident that it's going to be okay. And it allows us to use more organs that maybe we otherwise wouldn't have or couldn't have to help more people.
That's super reassuring to hear, because I don't think most people have any idea that that's something that you guys can do.
Yeah.
Right? I know a lot of people how fast technology changes, and especially in the field of medicine, how quickly all of it, the doctors I've talked to here on this podcast, from the time they've started to the stuff they're able to use now, they say, it's incredible stuff that comes out. And a lot of people build, well, when will we ever just have artificial organs that we can throw in? Maybe somewhere down the road.
Yeah.
You can never say no, but that is pretty close to, before it goes into your body, hey, this works.
Yeah, right. We give, like I say, I joke around. Maybe it's not the right euphemism, but we give these organs a test drive.
Right.
And
exactly.
we just make sure we're kicking the tires, giving it a test drive, making sure it's okay, making sure it's safe. And there's still some risk, but we've really reduced it, and we've now able to use organs that we were skittish about and didn't want to use because we didn't want to jeopardize the person we're putting it in's life or health.
Right.
Now we have more confidence, and so we can help more people, and it's really wonderful.
What is just before I get into some of these other questions here? What is the most common transplant that's done in people?
A kidney transplant.
It is the kidney
for sure.
Okay.
Kidney. There's so many people on dialysis today, and there is sort of an epidemic of kidney failure. I'm a boomer, so there's a big bulge of people in a certain age group that are getting older. They're going on dialysis to keep them alive, and the reality of it is that in terms of quality of life and even costs, kidney transplantation is always the way to go.
Okay.
And I think everybody who knows somebody or is, on the verge of getting on dialysis or is on dialysis should talk very seriously with their doctor. Say, listen, is transplant an option for me? And can I go visit with a transplant team if that's the case and see what I can do?
Oh, that's great advice. Now, let's get into a little bit of the partnership now with Monument Health. So when Nebraska Medicine started building this formal partnership, what stood out to you? What made you feel what made you feel confident that this is something that's going to work?
So it is a real partnership because it's a friendship. So Paulette Davidson, who is the CEO of Monument Health, was sort of my quote unquote partner. We were at the University of Nebraska. I was the surgical or medical person running it, but she was my hospital administrator partner. So she was the executive director of Transplant. So She came from Indiana, I think it was, and got a new job in Omaha. And the senior leadership for the hospital said, okay, you need a hospital, you need a partner, you need a dyad kind of deal. I want you to meet Paulette Davidson. And, we just became thick as thieves, and we proceeded to not only do great things together in terms of at the health system, but we became friends. And then, she was very talented, and, that was just a starting point for her. And obviously then she came up to Rapid.
Yeah.
And, worked her way up to the leadership position she's in today.
So this really is, this is, this goes back to a friendship that's kind of blossomed in now to this great partnership for transplants.
100%. And I give credit to Paulette. She said, listen, we can use Transplant up here. What do you think? There's a lot of other people who are, want to date us, kind of deal.
Yeah.
But I think it'd be better if it was your team from Nebraska, Alan. And I said, yeah, it makes sense. And then when you look at, Rapid City, Omaha, Nebraska, South Dakota, culturally, nothing's the same, but man, we are really close.
Oh,
right?
It's super similar. This whole region is very, it's tight, honestly.
It's tight. Yeah, and so we all think the same. We have the same issues. A few people live in the Rapid metro area. A lot of people live in the Omaha metro area, but most of our patients come from other places, and everybody's got to go a long distance. Everybody's farmers and ranchers, and we have people, Native Americans. So we deal with, so we just culturally, I think, are a good fit, and we quote unquote get it.
Yeah,
and so I think I think it's just a really good partnership because of that.
Well, let's say someone in the Black Hills, they've been told that they may need a transplant. Obviously, like you've talked about a little bit, that's a life-altering moment. I can't think of a bigger life-altering moment, honestly. So how does this partnership kind of change their path compared to trying to coordinate care across states, on their own?
Yeah, so I think anybody who's had serious health issues know that navigating the medical system today is really hard. I'm trying to use good on the air podcast language, but it's challenging, right?
Yes.
Even for people who are in medicine are connected, it's hard. I can't even imagine the uncertainties and the frightened nature of the whole experience for everybody. So what we do is we work very closely with all the ambulatory care people, the outpatient stuff, the inpatient physicians, the hospitalists, all the people who are here and live here. We have a very nice relationship with them. And somebody will say, we want you to see Mrs. Jones. We say, great. And we have a clinic up here. So we come up here twice a month. We come up in the jet, the Nebraska Medicine jet, which I came up in this morning, and barring any horrible weather, because we don't like to fly in bad weather.
No.
But we have a clinic up here at Monument Health, and we'll see people in the clinic. We'll talk to them about the transplant. We'll tell them, we think you're a candidate. We'll get as much testing as we can done here locally. And eventually say, but I think in the end, you're going to have a road trip down to Omaha and spend a couple days with us down there. But we do a little screening and education here locally and get to know these people and answer important questions and give them resources and kind of try to smooth out the anxiety that they're going to have, because they do. They get bad news and they're scared. And so and I think knowledge is power. So the more we can help them out, really it helps it out. So
is that, like I said, just to be clear, the transplants, the surgeries don't happen here in Rapid City. You have to go to Omaha for that.
That's correct.
Is that the closest one that you know of around? I suppose you could go to Denver or Minneapolis, Rochester, obviously.
Yeah.
But I suppose Omaha would be.
So I guess I don't have a map in front of me, but
it's got to be.
It's pretty
close.
Equidistance, right? Everything's about 8-hour drive,
right? Exactly.
Everything's about it. So I just Rapid City is a wonderful place, but I wouldn't say you're in the middle of nowhere, but
we kind of are a little,
right? And and that's kind of a good thing in so many ways.
Sometimes, for
right?
sure,
it's kind of nice. You fly in here, you look out the window of the plane. It's just absolutely gorgeous country. It's just beautiful, but so people have to go a distance, but as a health system and stuff like that, we get it. We have the resources. There's housing close to the hospital. We have, for people who need gas money, because a lot of people don't have a lot of money. We get that. So we have things set up to help people to kind of, lessen the blow of the whole thing. And a lot of it's financial.
Of course.
And so we try to do our best to help with that. And I would also say, South Dakota Medicaid has been a really great partner. They really have. I've worked with them. I've talked to them. they really do look out for the people of the state. These are people I meet, and so I've been really happy about that. And I also we have a really good relationship with Indian Health Services, so we deal with them a lot of that as the payers. So we work very closely with them to help kind of make it as smooth a process as possible under challenging circumstances.
Well, and that's kind of leads into my next question a little bit that you kind of touched on briefly, because you're sharing this care between two systems. I mean, it's the University of Nebraska, it's the Monument Health here, of course. So communication has to be seamless for something like this. So how do you guys make sure that patients don't feel like they're being bounced around? I mean, you kind of touched on it a little bit. But, to make sure they feel supported, is it just that constant communication? Is that the big key?
Yeah, I think, once we kind of get people plugged into our system, we are friends for life. Yeah. I think that we have wonderful nurse coordinators who are sort of our frontline health providers. And so they are constantly talking to these patients directly, saying, listen, you need to repeat your labs. How are you feeling? You're not feeling well, go to the ED. We have relationships like Matt Werpe, who's I think he's still the head of all the hospitalists here, who work on that. We have a great relationship with them. So we have wonderful communications at so many different levels. I'm just naming a couple things, but so everybody knows each other. Everybody's got each other's phone number. Everybody's texting each other. So in the end, that really improves the coordination of care for people who have complex medical problems.
So for people that are listening to this podcast right now, like you said, this is such a challenging moment for them when you realize that a transplant is going to be necessary. They're going to be scared, overwhelmed, I think is an understatement when you talk about something like this. What would you personally want them to know about your team and this partnership? You've talked a lot about the friendship, the communication, but is there anything else that if you really wanted to stress to them, look, we are going to give you the absolute best care we can give you?
Yeah, so I appreciate you asking that, Mark. So for sure what I can assure people is that you are going to get the highest level of medical surgical care anywhere in the world. I mean there are equals.
Of course.
But you're not going to go anywhere to get better. You're not going to get state-of-the-art, cutting-edge, best opportunities, most thoughtfulness. That we're going to get that for sure. But people ask me what makes us different or better, and I do believe it's just that warm Nebraska blanket we put on people. We get it. They're coming from the ranch. They're coming from other places. They're coming from long ways away. They don't have a lot of resources. We get it, and we are going to make this process as not painless, but as inviting as possible to you for you to go on this journey. And we're going to do it with you.
Right.
Like I said, it's just this partnership we make with our patients. We have a social contract with them, and that's our culture. And what I tell people are, like our nurses are the first people that meet our patients when they show up in our clinics. I remind them, I say, this is our job, right? So we do it, same thing every day, and it's kind of, there's routines to it. I say, well, when that person shows up in our clinic, you have to understand this is arguably the most dramatic moment in their life. And every minute of this experience is going to be seared in their brain, and they're never going to forget it. And so whether it's like the birth of a child or everybody remembers every little detail.
Right.
And we remind ourselves of that all the time so that when people do show up, we're trying to always put our best foot forward and help people in whatever their unique circumstances are, navigate whatever's going on.
I love that analogy that you gave, and it kind of reminded me of another doctor that I interviewed at Monument Health who said, I could go into a night of being on call, and I could do 5 or 6 epidurals, right? He said, I've done thousands of these. He said, so to me, I'm like, oh, it's another epidural. Here I go. I got to do the thing. But this, to that person getting it, could be their very first. And he said, so I have to walk into that room with that same mindset of, hey, we're going to be okay. We're going to get this done. This is, you're going to be fine. I'm very good at this. You're scared. I understand that. But as a team, we're going to make this work.
I appreciate you saying that. I think, we want to provide reassurance.
Yeah.
Not false expectations. We're honest with people.
Right.
We tell people, most people do okay, but not everybody does. It's still a high stakes game. And so, but we're upfront about people.
Yeah.
We believe in transparency. I tell patients, I said, there's no such thing as a dumb question. I said, this is, unless you've done this 10 times before, which I know you haven't, I mean, anything you want to ask is fine. Write down your questions. Give us a call. We don't want you laying in bed at night worrying about stuff. Talk to us. Ask us. This is like, again, a partnership.
Yeah. This might be a kind of a weird question to ask, but as you've done this as long as you have, you obviously thoroughly enjoy the work that you do. Are there transplants that you enjoy doing more than others? I don't know, that you're like, yeah, this is the one I know is going to help. I know it's going to make the most difference. I know it's going to be. Do you go into those? Do you have any like that?
I don't know. I mean, I think, so I was just giving a talk somewhere out of the country at another place, and so I wanted to I counted up how many transplants they wanted me to give a talk on liver transplantation and stuff like that. So, we've done about 4,500 liver transplants, which is a lot, right? But we've also, of those, 1,000 of them have been in children, and most of and I would say the majority are in babies, because that's just how it goes.
You can go that low you can have babies get a transplant.
Right. So getting to all that, I guess, if you have to say,
right, how
do you feel about it? I say, if it's another kind of, another dude like me who's a little long in the tooth, it's just like, okay, that's fine,
right.
But when you see these young families who are adult, really are facing really, really difficult times with a sick child, oftentimes a baby, less than a year of age. I mean, those things, just take on a higher level of intensity and maybe emotional investment. And I think so. And when you ask about that,
right.
And typically the transplants we're doing in those type of age groups are technically a little bit different. So we're doing living donation. So a family member is donating a piece of liver, or we're taking a deceased donor and just cutting off a small piece of that. So the technical challenges are elevated, and the stakes are high.
Yeah.
Children are they're children.
Right.
My goodness, I mean, how could it not be more special, right? So,
exactly.
And that's a privilege to be able to do that.
Oh, that's a great answer. Well, Dr. Langnas, I'm really glad that you found time to come up and do this. I really appreciate talking with you. Down the road, I would like to, if you're ever back and you need another cup of coffee and just want to chat for 25 minutes, there's lots of, obviously, transplant surgeries. There's a ton of stuff we could talk about on this. You can get super specific on everything. And eventually, if you're ever up for it again, I'd like to get more specific into some of these because it's obviously just an unbelievably interesting procedure that has to be done. The fact that it can be done, the fact that it saves lives is, it's something I think needs to be discussed even more. So I really appreciate you coming in, Dr. Alan Langnas, Professor of Surgery, Director of the Nebraska Center for Transplantation, Chief of Transplantation Surgery. You got a lot of stuff on this list I could go on and on about, Doctor. But thank you for coming in and doing this. I appreciate it.
Well, thanks, Mark. I really, really appreciate the opportunity.